Hello, everyone. Welcome to the Chest Pulse podcast. My name is Matthew Barraza. I'm a pulmonary and critical care fellow at The Ohio State University, and I'm excited to be here today with a bunch of our guests. I'm also joined by my co-host, Dr. Renzetti, who's going to introduce herself now.
Hi, I'm Maddie Renzetti. I'm an intensivist out of Montefiore Medical Center.
And then I also have Dr. Minami here with us.
Hi, my name is Taro Minami, pulmonary critical care guy. I'm a chair at the ultrasound and chest imaging section at Chest Network. So I guess I'm just sitting here.
And then we're also joined by our two guests of honor here, the experts who've been instrumental in advancing this field. First, we have Dr. Abhilash Koratala, who is a nephrologist intensivist and clinician educator known for his work in point-of-care ultrasound and cardiorenal physiology, as well as Dr. Eduardo Argaiz, whose research has helped shape how we understand and apply VExUS in clinical practice. So in this podcast here, we're just going to be discussing what VExUS is, kind of a little bit of their thoughts on this, and we're going to ask a few questions and get their feelings about this right now. So one of the first things we wanted to start with was just make sure we're all speaking the same language. So when you think about terms like fluid status and venous congestion, how do you guys define them in your clinical practice, just to make sure our listeners are on the same page as us?
Well, this is completely different things, right? So fluid status and venous congestion should never be equated as the same thing. Venous congestion is the consequence of right heart failure, and that can be exacerbated by volume overload, of course. So there's some relationship to volume, but it's not necessarily related to volume in patients without heart failure. So volume status in patients without heart failure has no relationship with venous congestion. However, there is heart failure, and there's a lot of heart failure. Mm-hmm. So when patients have heart failure, and I mean right heart failure, of which the most frequent cause is just a left-sided diastolic dysfunction, then volume overload would tend to create the consequences of high right atrial pressure, and that would then lead to peripheral venous congestion.
Mm-hmm. And everyone's used to talking about the left heart failure, and we just forget about the right side a lot, I feel like.
Yeah, sure. So that's something that VExUS really started to bring it back on the map. So now we are performing some substantial quantitative assessment of the consequences of right-sided heart failure.
And then Maddie, did you also have another question for them?
Yes. So the first part of VExUS is IVC measurement. And I struggle with this sometimes because I feel like IVC is one of the more controversial parts of POCUS. So I was wondering if you both could comment on some of the limits of IVC measurement in the context of VExUS. I recently read that IVC maximum size can vary in different populations, and the 2 centimeter mark might not even be applied to all populations. And so when do you guys look at a patient and decide to be a little bit less rigid in your IVC measurements?
Exactly. I think traditionally we have used 2 parameters for IVC, right? We have used the diameter and collapsibility with inspiration. For the VExUS study, they have used a cutoff of 2 centimeters, and they looked at Doppler abnormalities in conjunction with the diameter. But the diameter has always been controversial. The data comes from Canadian patients, so it may not be necessarily applicable to shorter people. For example, in an Asian study, 1.7 centimeters has shown to better correlate with elevated right atrial pressure as opposed to 2 centimeters or 2.1 centimeters that we traditionally use in echocardiography. Also, it might be worthwhile to look at the IVC in both long and short axis. That way, we don't fall prey to the cylinder effect if we look at it only in the long axis. And also the shape in the short axis gives us a better idea of whether it's full or not. Actually, the same VExUS group has published a study very recently, I think last week, where they incorporated IVC collapsibility also as a criteria in addition to size alone. But collapsibility, as you know, it depends on patient's strength of breath. So yeah, there are so many issues to be taken into consideration practically, but you use clinical discretion.
The original VExUS paper, the reason why they only used the IBC size and not collapsibility was because this was a retrospective analysis of data, and that was not available. And if you talk to William or Philippe Rolla, I mean, they will all tell you, of course, we're trying to assess whether right atrial pressure is high. So, of course, we'd pay attention to collapsibility. The data was not there for the analysis.
And you kind of touched on this a little bit with the different populations of patients. We were talking about this too, since the initial studies were looking at the cardiac surgery population. How do you guys apply this to ICU populations? Do you think about like different ICU populations differently? What do you think we can apply, and what do you think we should be more cautious about?
Well, for start, you said the original VExUS paper was done on cardiac surgery patients. But we have to be aware that that's the original paper for the score. So there's a VExUS score, and this VExUS score is just a combination of 4 parameters: the IVC, the hepatic vein, the portal vein, and the intrarenal veins. And it assigns a numerical value to some of the alterations seen in these veins to create a final score that goes from 0, 1, 2, and 3. That's based on alterations on flow on these venous sites. And this is really what's called the VExUS score. However, there's much larger literature regarding what I call venous Doppler, which is not the same, but it's telling us the same thing. I mean, we're assessing venous congestion and how right atrial backflow is affecting the normal flow patterns in this venous sites, so portal, intrarenal, and hepatic. So the literature of venous Doppler really goes even back to 1990. There's some papers on portal vein Doppler. The original intrarenal venous Doppler paper came out, I think, in 2016. And some of the more nuanced papers on portal vein Doppler came in 2018, I believe. And it was not until 2020 that we are trying to say this is the original VExUS paper. Well, this is the paper that called it VExUS. However, the literature of venous Doppler goes way back, and there's way more populations that not only include cardiac surgery that have been studied from the past. And of course, now that this is gaining some acceptance, it's being studied in more and more populations. What I would tell you, and I think Abby will agree, this is not whether this can be applied to ICU or emergency department or hospital care. It's really applied to any patient who has some type of cardiac dysfunction. And so if you see papers of venous excess ultrasound score of VExUS in ICU, well, this is usually, if you read the fine print, this is a cardiac ICU. And that's where, for example, Guinaud, the French researcher who's amazing, he does this in a cardiac ICU where he finds that portal vein Doppler is a really good marker of accurate response to diuretics. And the title says in ICU. He doesn't say cardiac ICU. I think that was because he wanted to publish in some critical care journal. But this is cardiac ICU where it's useful. And if you actually look at the literature of VExUS in a medical ICU where the main diagnosis was sepsis and the prevalence of heart failure was low, then they tell you it was really not a very good tool to predict acute kidney injury. Well, of course.
Exactly. I think it just depends upon the likelihood of a patient having venous congestion, which is pretty high in dedicated ICUs where you have heart failure patients or cardiac surgery patients. So definitely that's a very clever step by the VExUS investigators that they chose cardiac surgery ICU, that you are choosing the appropriate population. But depending on where you are working, in which ICU, you always need to keep in mind what are the caveats and what's the likelihood of patients having venous congestion. If you're having a septic shock patient, when you catch them early, it's less likely that they show venous congestion, right? Even if they are fluid resuscitated, because they are so vasodilated. And I work in liver ICU. And in liver ICU, it's very difficult to get like reliable hepatic or portal vein waveforms. You can get the waveforms, but they might not be reliable for interpretation. So you have to search for other veins such as femoral. So yeah, essentially, yeah, what Eduardo is saying or I am saying is like essentially depends upon what kind of patients you are evaluating and what's the likelihood of them having venous congestion.
Do you mind expanding a little bit on the liver failure population? That's one of the areas I struggle with most in figuring out their true venous congestion. I mean, their IVC and portal veins are already scarred and distorted by their own anatomy.
Yeah. Liver patients are very tricky to do VExUS or POCUS in general. Um, One thing is like their IVC can be relatively small and collapsible, but it does not necessarily mean that they require fluids, even if you trust the IVC, because their problem is they tend to have significantly elevated cardiac output. So if their cardiac output is already 8 liters, what's the point of giving albumin, right? So you don't need to wait for the right atrial pressure to be elevated. And most of these patients tend to have subclinical diastolic dysfunction, and if you load them with fluid, they develop pulmonary edema, which is the problem that you see in terlipressin-based studies. And as you pointed out, there are definitely structural issues with the IVC because of caudate lobe hypertrophy or increased intra-abdominal pressure, making it look small. Or Eduardo has seen some patients where IVC is like dilated at baseline, despite not RAP not being elevated. And coming specifically to VExUS, like hepatic vein tends to be blunted at baseline, which means you can't like really discern systolic and diastolic waves. It becomes more or less continuous. So when it becomes continuous, it's hard to know if the cardiac pulsatility would be transmitted to the hepatic vein or not. It's debatable. We don't have much data on that. If the patient doesn't have portal hypertension, but once the patients have portal hypertension, it becomes less reliable. And portal vein tends to be pulsatile at baseline, not like the actual crisp cardiac pulsatility, but more haziness because of arterioportal connections, and you might not be able to use that. So you're relying more on intrarenal venous flow. And other things you have to look at, like which are not in the liver, such as IJV in ultrasound or SVC if you're able to access that from subxiphoid or femoral. However, like these are all based on our experience rather than having formidable published data.
So in those cases, you're looking at femoral vein pulsatility?
Correct. Femoral vein pulsatility and stasis index more precisely, which means if there is more flow interruption, that means it's more abnormal. Yeah.
And you mentioned more dependence on the kidney. Matt and I were bonding earlier about how difficult it is for us to find the renal vein. Do you have any practical tips for consistently finding the renal vein, especially in our patients with, say, chronic kidney disease?
Yeah, well, the tip would be get away from that vein in chronic kidney disease. If the kidneys are small and thin, and the cortex is not well, even if you have the greatest machine and you're the best echocardiographer, and you'll get a signal, that signal might not be reliable because the compliance of the kidney parenchyma is completely different when there's scarring. And I don't know if you've seen this, Abby. I'm sure you have, but sometimes you can see an interrupted intrarenal venous flow. Even with a CVP of 0 and completely normal heart function in advanced CKD. So even if you are the greatest echocardiographer, you'll still get some uninterpretable data. So again, if you have advanced chronic liver disease, and that means cirrhosis, with very small hepatic veins, a very small and nodular liver, then get away from hepatic and portal. And intrarenal works great, depending on the question you're asking. If you have a very small kidney or a very thin cortex, and it's advanced CKD, then just get away from the renal veins, and portal vein will be very helpful if you're assessing right heart failure.
Except in cirrhosis, right?
Well, that's exactly what I was really burning to learn from you guys. So whenever I do VExUS in the ICU, in my ICU, I do more and more VExUS for the past few years. Especially, I had a session with Abby like 3 years ago at CHEST. But I always have trouble finding the renal, intrarenal venous Doppler. So it was coming to the point that I'm very often omitted, not because it's just limited time, etc., etc. I tend to limit. Now I find the concept of the modified VExUS that they're kind of cutting off the renal venous Doppler. So could you comment on these things? Is it okay, not okay? What's the problem of cutting off the venous Doppler? Because that's always I struggle to get some nice signals.
You go ahead, Eduardo, because like you are the proponent of portal first approach.
Well, first things first. The original VExUS score was conceived with the renal vein as an optional addition. So it's not necessary for the conception of the score. Of course, it was included on the paper, and then all that was calculated to see if this score was actually reliable was done so by including the intrarenal vein. So the data of excluding it is just not there. But practically, I mean, all of us people who are doing venous Doppler all the time, I can tell you that most of the time, if you're choosing the right population, which is populations of patients with a high pretest probability of venous congestion, so that's right heart failure, right? So you have to have right heart failure. If you're choosing this population, and we did this study a couple of years ago, we included patients with with any kind of pulmonary hypertension. So we just included patients with a TRV max greater than 3.4. So a high probability pulmonary hypertension, doesn't matter if this is group 2, group 1, group 3, group 4. And we studied the correlation between portal and intrarenal Doppler to see if we could get away by only doing portal vein. And we found a fantastic correlation to the point that I think kappa was 0.94. The interclass correlation coefficient was greater than 0.9. And the concordance was greater than 94%. And this was done by internal medicine residents with very little training. They performed the venous excess score, the intrarenal, the portal vein. Then I performed it. Then another echocardiographer performed it. We were all blinded. Sometimes we were having 4 to 5 people scan the same patient just to see if we get the same results. We got a very good reproducibility, but more than that, we found that intrarenal Doppler was really not necessary because the same information was obtained with portal vein Doppler. But this is in a very sick population of patients, a TRV max of 3.4 or greater. So high probability pulmonary hypertension. And you see, if 3.4 is the cutoff point to get included, then of course the average TRV max was greater than that. And you can imagine how this population of patients is very sick. And so if you start doing this in patients with very early heart failure or a very subclinical heart failure, such as the studies done with B lines that, 0.5 B lines per field is what they define as subclinical pulmonary edema, then what you would find is that all portal vein Dopplers will be normal, while you can still see some very subtle early findings in the intrarenal veins. And the point is, intrarenal Doppler is extremely sensitive. So very little degrees of congestion. I have seen intrarenal venous Doppler become altered before IVC, before long ultrasound. And portal vein Doppler is really, it will not become altered until congestion is extremely severe. So that's the point where they might not agree, right? So if you have a very early heart failure with very mild congestion, maybe this is an ambulatory clinic trying to diagnose congestion early to intervene, then portal vein Doppler is not going to be useful because you're going to see all normal portal veins, right? And then intrarenal might be able to detect congestion very early because it's very sensitive. Now, on the other side, if you're trying to study patients with torrential tricuspid regurgitation, systolic right heart failure, very severe pulmonary arterial hypertension, then of course, renal Doppler is going to be altered no matter what you do. We actually did a study on severe TR. And most of them, I think half of them were secondary TR, but half of them were primary valvular or irreversible tricuspid regurgitation. And of course, we found that the only marker that tracked fluid status in this population was the portal vein, because they were such severe forms of heart failure that even in the compensated or euvolemic state, the intrarenal Doppler is still altered, while portal vein Doppler becomes abnormal with volume overload, and it can become almost in every case back to normal, or at least lower than 50% pulsatility once we decongest the patients with diuretics. So just to recap, sorry for the long answer, for very severe populations, portal vein Doppler is a little bit more useful because it's harder for it to become altered. For very early heart failure, then intrarenal gets altered easier, or it's more sensitive. And if you select a population that's sick enough to have both alterations, that you get the same information from both.
That's extremely helpful. Thank you so much, Eduardo. Is it too much to say that for us working in the intensive care units, everyone is super sick? It might as well be fair to say that portal vein might be the first step, or that we have very limited time. We really have, we have to pick up some examination. May I assume that you may pick up portal vein?
Well, I would say yes, but let's see what Abby says.
No, I think for intensive care unit purposes, I think it's fair for all the things that Eduardo mentioned. It's the last way to get worse and the first way to get better. So even for monitoring, it's helpful. But from my nephrology aspect, as we just discussed, that renal vein and hepatic are probably more sensitive tools, and they get altered quickly. If you're sitting in the nephrology clinic or pulmonary hypertension clinic, maybe it might be worthwhile doing those parameters too if you're longitudinally monitoring the patients. But in the ICU, maybe portal. But with the caveat that portal also has some technical issues, right? You can't just say it's so easy. Sometimes, generally it doesn't need EKG, but if you don't have EKG, sometimes it's possible that we confuse respiratory variation in the flow with cardiac pulsatility, especially when the patient is breathing rapidly. Or there are certain unknown things, generally we tend to sample the main portal vein, but sometimes we have observed that one of the branches of the portal vein can have more pulsatility than the main portal vein. So I would take it with a pinch of salt. And I'm a believer that the more parameters we have, the better it is. That way, if one of them is discordant, we can apply our best clinical judgment to see how rest of the parameters are pointing. That's why I make fun of Eduardo. If Eduardo is doing it, whatever he says, I would trust. But if somebody who just learned VExUS is doing, I would probably not trust portal only approach.
I completely agree with that answer.
And with that, a lot in the ICU, on ventilated patients, do you guys approach this differently at all?
Yeah, in general, there is no difference in the technique of VExUS or how you interpret, right? Because VExUS is only telling us the degree of congestion, and whether that degree of congestion varies because of pressure overload, is it because of the PEEP, or is it because of mechanical ventilation in general, or related factors like the patient's lungs are not so good and have consequent RV dysfunction, or it is all because of fluid overload and just heart is not able to tackle that fluid overload. So the point, or pericardial effusion for that matter. So there can be any cause that basically increases the right atrial pressure, and that transmits to the systemic vein. So VExUS is going to tell you if VExUS is abnormal, it's grade 3, it's grade 3. You have to figure out the cause and treat it appropriately. So we wouldn't really change how we interpret VExUS just because the patient is on mechanical ventilation. There have been studies that looked at how much PEEP affects portal vein pulsatility, for example. But again, it doesn't really go linearly. It depends so much on the patient population that you are studying. It's not, there can be healthy volunteers where it hasn't shown much difference. But when they did that in the cardiac surgery patients, they showed that PEEP of 15 is associated with pulsatility of about 45% or so, which is abnormal. So again, it depends on the transmission of intrathoracic pressures to veins.
Yeah. And even if they're, because I have a lot of people who say, oh, they're ventilated, we don't have the data for this, but that's still the pressure that their system is feeling. And if you are still seeing these high grades of congestion, it still means in this ventilated state with these settings, they are having this congestion. So we still likely need to get fluid off, right?
Yeah, well, correct me if I'm wrong, Abhi, but the original VExUS paper, many of the patients recruited were mechanically ventilated.
Yeah, that's what we got from the authors, but like the study itself doesn't mention what proportion of patients were mechanically ventilated. But the parent study of VExUS, where they published about portal and renal veins, that study definitely says that portal pulsatility was higher in people who were mechanically ventilated. Yeah, so we don't know the exact number of patients.
Because they're sicker also. So,
Yeah.
and what I would say is, if you ask the correct question, then this becomes a non-issue. And this is probably a paradigm shift that I would like to propose, and is to look at venous Doppler not from the perspective of fluid resuscitation or fluid deresuscitation, but from the perspective of congestive organ injury. And so this is easy for me because when I look at the patient, I'm a nephrologist. So when I'm consulted on a patient with venous congestion, I'm usually consulted because there's already been a consequence, which is congestive organ injury, right? So I'm on board in the case. There's acute kidney injury, there's oliguria, and I want to figure out if there's venous congestion and if this is responsible for acute kidney injury. Because if it is, then I might take additional efforts to relieve congestion, right? So let's say we have a ventilated patient with a high PEEP that's developing acute kidney injury and oliguria. And I get on board in the case, I look at the chart and I see this patient has systemic sclerosis with group 1 pulmonary hypertension and is now intubated because of sepsis. Okay, so this might be septic AKI. But then because there's already baseline cardiac dysfunction, the probability of congestive kidney injury is extremely high. So how do I navigate these two possibilities? Well, one of them is doing portal vein Doppler, right? So portal vein Doppler shows me 120, 130% pulsatile portal vein. That means flow is going back from the portal vein to the gut, right? To the intestine, to the spleen. This is catastrophic tricuspid regurgitation that's flooding the organs, and it's probably leading to hepatic and renal congestion, no matter the cause, right? And so then I go back and I say, okay, how do we improve this patient's congestion? And some pulmonary hypertension specialists might say, I don't think we should take fluid off. I think first we should prone the patient, lower the PEEP, improve PCO2. That would decrease pulmonary artery pressures. Maybe the tricuspid annulus will get a little bit smaller. Tricuspid regurgitation will decrease in severity, and that might be enough to decongest the kidneys. And I would say, okay, let's try this. Maybe this is not a volume problem, but we need to have a hypothesis of what's causing the congestion and how to address it. But my question is not whether this patient's fluid overloaded or not. My question is this congestive kidney injury? Yes. So how do I get rid of congestion? Well, then I need to figure it out with the rest of the team. If this venous congestion was done by a pericardial effusion who has greater pressure than the diastolic pressure of the RV, well, then the treatment will be a pericardiocentesis, right? Not fluid removal. And so if your question is my patient having congestive organ injury? And the answer is yes. Then the next question is, how do I improve it? And you see how that removes volume guessing from the equation.
Yep. I think, for, like you said, kind of picking the patients where you already have a high pretest probability of venous congestion, they come into the ICU, and regardless of how they're looking, it's probably good to just get an idea of what does their venous congestion look like at this time. And then as we're diuresing, because usually it's a few days in and we get to the point where somebody says, oh, I think they're like euvolemic now, or they are intravascularly down or something. Well, it's good to have that starting point of this is what their congestion looked like. Now I'm checking it again while we're having these questions. I still see signs of congestion in the portal vein. And that's, like you said, one of the last veins that's going to have that congestive status. So if we're seeing that, we probably should go, provided, like you said, there's not another cause of the congestion. And if we think it is primarily fluid, keep going with that fluid removal.
Yeah, so for monitoring, that's great. And I use this a lot, especially in severe or torrential tricuspid regurgitation. Portal vein would be very good and useful tool to monitor decongestion, because what else can you do? I mean, what's the expected CVP target for somebody with torrential TR? Well, it varies patient to patient. What's the IVC target? Usually always dilated, always plethoric. The hepatic veins and the intrarenal veins may always show severe alteration. So in a patient with torrential TR, your hepatic vein will always show an S wave reversal, right? Because severe TR. It's just your fused CV wave and your CVP waveform. That's exactly the same. What is surprising to me, this was surprising to me, but is that portal vein is not fixed. And it does tend to track fluid status in some surprising way that I'm not entirely sure what's the full explanation behind it. But definitely what's behind this should be that it's harder for the portal vein to become pulsatile because the right atrial backflow, the tricuspid regurgitation jet, has to go through the liver sinusoid all the way to the portal vein, and there's some resistance to flow. So it's an isolated vascular system. So the fact that we see very high pulsatility usually means venous compliance is completely lost. So veins are very dilated. And this is usually, there's some component of fluid because, of course, to dilate a vein, you need to fill it up with something.
Well, this has really been awesome, guys. And I could talk about this forever. I feel like I wish we had more time. We'll probably have to close this up now. So, and to close, I guess, I want to thank both you guys, Dr. Abhilash Koratala and Dr. Eduardo Argaiz, for joining us on the Chest Pulse podcast. Thank my co-hosts, Dr. Madelyn Renzetti and Dr. Taro Minami, for being here. And thanks everyone for tuning in.
Thank you so much for joining us, Siva. Turned me into a portal vein truther.
Oh yeah, I'm going to be doing it way more.